Hello. The topic of our webinar today is what clinicians need to know about available therapeutic options for COVID-19. Miora, as you know, is a nonprofit organization whose mission is to provide an opportunity for students to conduct cutting-edge health and STEM research through no-barrier experiential certificate internships. The founder and president of Miora is Dr. Aslam Equals, who is a pediatric infectious disease specialist. I will be the presenter today, Willie Troutman, retired public health nurse with Los Angeles County Department of Public Health, and I was the adult immunization coordinator with the Vaccine Preventable Disease Control Program. I am a board member with Miora, a retired United States Air Force nurse, 22 years, currently working as a home health nurse, and for fun, I am a certified Silver Sneakers exercise instructor. The objectives for this webinar are, number one, describe the current trends of COVID-19 in California. Number two, discuss testing options and patients at high risk for COVID. Number three, describe the outpatient management and available therapeutics for the outpatient management of COVID-19. Number four, describe the rebound, data on prevention of severe disease and data on long COVID. Number five, discuss where to find more information about COVID-19 therapeutics and availability. To start with the weekly trends in COVID-19 cases and deaths in California, this is data from the CDC as of January 4th, 2023, depicting the weekly case rate of 158 per 100,000 and the weekly death rate of 0.8 per 100,000. Now, looking at the surveillance data from the CDC for the variants of concern in California, as of January 7, 2023, the Omicron BQ1.1 lineage makes up 40.6% of the circulating variant, and the other lineages, such as the XBB, still trailing behind at about 7%. Data from the CDC through January 3rd, 2023 shows a 7-day moving average of around 767 new hospital admissions. COVID testing in California continues. However, in the period through January 2nd, 2023, the CDC does not provide the percent positivity, which is the percentage of all coronavirus tests performed that are actually positive. Also, for the period ending on December 29th, 2022, the CDC does not provide the data for the tests performed. This slide illustrates the risk factors for severe COVID-19, which includes, number one, age, which is the strongest risk factor for severe COVID outcome and risk for deaths being 25 times higher in people aged 50 through 64 years as compared to those between 18 through 29 years, with the risk increasing substantially at 65 years and older. Number two, underlying conditions: obesity, diabetes, chronic kidney disease, chronic obstructive pulmonary disease, neurocognitive disorders, coronary atherosclerosis, and heart diseases increases the risk of severe COVID, and risk for progression and poor outcomes increases with increasing numbers of underlying conditions. Number 3, race and ethnicity. People from certain racial and ethnic minority groups are more likely at a younger age to experience severe COVID-19, and as barriers to accessing healthcare are more common in certain racial and ethnic groups. This slide illustrates key findings from one large cross-sectional study where the COVID-19 death risk ratio was higher for select age groups like those over age 85 years. Marked in green, which further emphasizes the fact that age is the strongest factor for severe COVID outcome. The study also demonstrated the risk ratio of deaths being higher in individuals with underlying comorbid conditions as indicated in blue. The depiction in this slide from the same large cross-sectional study reiterates that the death risk ratio increases as the number of comorbid conditions increases. Now we will move on to the medical management for mild to moderate COVID infection, where primary care physicians play a key role to help reduce the risk of hospitalization or death in high-risk patients. We will discuss the authorized or approved therapeutics for the treatment of mild to moderate COVID infections in adults and children with positive results of the SARS-CoV-2 viral testing who are at high risk for progression to severe COVID, including hospitalizations and death. Let us first step back to see the available tests for SARS-CoV-2. The tests include molecular tests such as PCRs that detect the genetic material of the virus and rapid antigen tests that detect specific proteins from the virus. Patients reporting a positive rapid antigen test or PCR are eligible for the therapy. To note, PCR is not mandatory to start therapy. Paxlovid has not been approved, but has been authorized for emergency use by the FDA under an emergency use authorization for the treatment of mild to moderate COVID in adults and pediatric patients 12 years of age and older, weighing at least 40 kilograms, with positive tests of direct SARS-CoV-2 viral testing. Paxlovid contains nirmatrelvir and ritonavir. Ritonavir is a strong inhibitor of cytochrome P450-3A. It is generally administered at a dose of 300 milligrams, 250 milligram tablets. Nirmatrelvir with 100 milligram tablet of ritonavir given twice daily for 5 days. One carton contains 5 blister packs of Paxlovid as co-packaged nirmatrelvir tablets with ritonavir tablets, providing all required doses for a full 5-day treatment course. From a timing perspective, Paxlovid should be started as soon as possible after COVID diagnosis and within 5 days of symptom onset. Special considerations for Paxlovid include, number one, renal impairment, where special packaging is available for patients with moderate renal impairment. Paxlovid is not recommended in patients with severe renal impairment. Number two, hepatic impairment, where Paxlovid is not recommended in patients with Child-Pugh score C, which refers to advanced hepatic dysfunction. And finally, number three, potential drug interactions, the details of which we will review in the subsequent slides. Paxlovid is contraindicated with drugs that are highly dependent on CYP3A for clearance and for which elevated concentrations are associated with serious and or life-threatening reactions. The drug interaction resources for providers have been added to this slide for detailed reference. The slide provides the details of the common drugs which can be co-administered without dose adjustments or increased monitoring. This list includes commonly used acid-reducing agents, allergy meds, antibiotics, pain medications, immunosuppressants, drugs used for diabetes, high cholesterol, and some respiratory conditions. Switching gears to our next therapeutic option, remdesivir, a nucleotide analog RNA polymerase inhibitor, approved by the FDA for adults and children 28 days and older and weighing at least 3 kilograms. This medication can be administered by IV infusion in non-hospitalized patients as a single loading dose on day 1, followed by once daily maintenance doses on day 2 and day 3. Again, from a timing perspective, remdesivir should be started as soon as possible after COVID diagnosis and within 7 days of symptom onset. Special considerations for remdesivir include, number one, severe renal impairment where it is not recommended. Number two, hypersensitivity reaction where patients need to be monitored closely during infusion and for at least 1 hour after the infusion is complete. And finally, number three, potential antagonistic effects of chloroquine on the antiviral activity of remdesivir. Moving on to our last therapeutic option, molnupiravir, a nucleoside analog that inhibits the SARS-2 replication by viral mutagenesis, is an emergency use authorization drug limited to patients for whom alternative COVID treatment options are not accessible or clinically appropriate. It is not authorized to be used in patients under 18 years of age. The dose being 4 200 milligram capsules taken orally twice a day for 5 days. Timing-wise, molnupiravir is used as soon as possible after a diagnosis of COVID and within 5 days of symptom onset. Special considerations for molnupiravir include: it is not recommended for use during pregnancy, given the risk of embryo-fetal toxicity. Number 2, not authorized for use in patients under 18 years of age, given the bone and cartilage toxicity. And finally, number 3, contraception is needed in females for the duration of treatment and for 4 days after the last dose, and males for the duration of treatment and 3 months after the last dose. Currently, the Los Angeles County Department of Public Health has implemented a plan to assist those eligible for treatment, including criteria and pathways to access medication. This plan includes ways for individuals to find urgent care centers, test to treat sites, and pharmacies. To be eligible, a person must be at an elevated risk for severe illness and hospitalization, including the following. Number 1, COVID-positive individuals must be 50 years or older. Number 2, or those unvaccinated or not up to date with current COVID-19 vaccinations. Number 3, and or must have one or more health conditions that have been associated with severe illness, regardless of vaccination status. The list of conditions is set by the CDC and includes a number of conditions, from chronic liver disease, neurological conditions, diabetes, and more. And finally, number 4, the extensive review of each medical condition can be found in the link on this slide. The Los Angeles County Department of Public Health has ensured that county residents are able to access medications regardless of insurance or healthcare access by providing county nursing staff who screens via call center and telehealth services. These services are provided over the phone 7 days a week from 8 a.m. to 8:30 p.m. This is a great resource for doctors and clinics that are unable to see patients due to insurance issues. We will now spend a few minutes on COVID rebound. So what is COVID-19 rebound? This is when patients with COVID start to get better and then begin to get symptoms 2 to 8 days after they have recovered and may test positive again. This rebound has been seen in patients who have received treatment, as well as those who have received no treatment for COVID. Paxlovid, one of the frequently used medications, have been associated with COVID-19 rebound. The good news is that there is currently no evidence that the additional treatment is needed for the rebound, and these reports do not change the conclusions from the Paxlovid clinical trial, which demonstrated a marked reduction in hospitalization and death. However, electronic health record data analysis may fully characterize the incidence and risk of disease progression associated with the rebound, and more prospective data would be needed to fully understand the pathophysiology and association with drug treatment. Please feel free to access the shared link from the CDC Health Advisory on COVID rebound after Paxlovid treatment. Data from CDC shows 1 in 13 adults in the United States have long COVID symptoms, which are defined as symptoms lasting 3 or more months after contracting the virus, and those symptoms which they did not have prior to COVID infection. 3 times as many adults between ages 50 through 59 have long COVID than those 80 years and older. Black and Hispanic individuals were more likely to experience long COVID-related symptoms and health problems compared to white individuals, according to a new study. Up to 180 days after testing positive, Black patients who had severe COVID-19 had higher odds of being diagnosed with chest pain, diabetes, and headaches compared to white patients. In addition, Hispanic patients who had severe COVID-19 were also more likely to be diagnosed with headaches as well as dyspnea compared with white patients. While bisexual and transgender adults were more likely to have current long COVID symptoms than adults of other sexual orientations and gender identities. This slide provides the link to helpful information and resources for your reference, in particular to the Test to Treat site locator, generally Therapeutics located, and CMS reimbursement information for oral antivirals. Let us now conclude this webinar with a self-knowledge check question based on current supply COVID-19 therapeutics should be considered for any COVID-19 patient who meets which of the following criteria? A, has mild to moderate symptoms and are within 5 to 7 days of symptom onset. B, due to current supply constraints, COVID-19 therapeutics should be considered only for individuals who are severely immunocompromised. Number C, no additional criteria needed. D, has 1 or more risk factors for severe COVID. E, A, and D only. I'll wait just a few seconds to let you really look at that question. So the correct answer is E. The reason for this is because oral antivirals are not currently supply constrained. Clinicians should consider COVID-19 treatment in non-hospital patients who meet all of the following criteria. Test positive for SARS-CoV-2, have symptoms consistent with mild to moderate COVID-19, are within 5 to 7 days of symptom onset, and have 1 or more risk factors of severe COVID-19. So this concludes the webinar. We appreciate your attention to this webinar and would love your feedback. Thank you very much.